Good afternoon. Welcome to the September 2022 edition of the ASC eJournal series. I am Dr. Reza and the chair of the eJournal committee, and I will be moderating the session today. I start with a very brief introduction of our panel. Dr. Walia is a member of the eJournal committee and will be the presenter today. She has completed her medical degree in India and completed her residency, as well as her search path and cytopathology fellowship at the University of Southern California. She is currently an assistant professor of clinical pathology at Keck School of Medicine at the University of Southern California. In addition to the eJournal committee, she is also a member of the advisory board committee for continuing certification at the American Board of Pathology. We are also very grateful to have with us the authors of the paper to be presented today from Loyola Medical Center in Illinois. Dr. Trabzonlu is a PG-Y4 resident and he will be continuing to a cytology fellowship at MGH, and he's the first author. And the senior author is Dr. Barkan, who does not need any introduction. Just suffice it to say that she is the immediate past president of the ASC, professor of pathology and urology, and the director of cytopathology, as well as the fellowship director at Loyola Medical Center. Thank you so much for making time in your very busy schedule to join us today. And as a reminder, this session is live and we encourage our audience to engage in our QA portion by posting your questions in the question box, and I will be monitoring it, and we generally dedicate the last 10 minutes or so to answer the questions. At the beginning of our session, we will have a poll just to see what are the audience distribution as far as your level of interest or practice in cytology. And with that, after that, I will pass the virtual podium to Dr. Walia. Thank you very much.
You have a pretty even split between pathologists and cytotechnologists. You got 57% pathologists.
Very good.
43% cytotechnologists.
Very good. Very good. That's how we like it. Very good. So with that, I will pass the virtual podium to Dr. Walia to take it over. Thank you.
Thank you, Dr. Reza, for the wonderful introduction for all of us. So today I will be discussing the article that is titled Telecytology Validation. Is there a recipe for everybody? This was published in the July-August edition of the Journal of American Society of Cytopathology, and it came out of Loyola University Medical Center. I do not have any conflicts of interest. So I'm very excited that we have the first and the last author of this article with us today. So Dr. Trabzonlu, who's the first author, and the senior author, Dr. Barkan, are both here as guest speakers with us to discuss this article and tell us more about it. And this is me. So telepathology is basically a process where images or videos from a remote site are transmitted to a pathologist to render an opinion or a diagnosis. In the last 2 or 3 years, we have seen widespread acceptance and adoption of telepathology. And also there is now a push towards rapid on-site evaluation using telecytology. We did a Twitter poll yesterday, and it seems like there is still a large segment of pathologists who have not started or who are not doing the rapid on-site evaluation with telecytology. And I think this article will be very useful for all of us who are not doing it. We have a fairly large medical center, Loyola, that did this study and provide us insight into how they did this, what modalities they used, and how the validation process was done at that center. So it is a great article for us to follow them or get some direction if we are wanting to utilize telecytology for ROSE. So at the end of this presentation, I'm hoping we will understand what is the process of validation of telecytology for roles. We will know who are the key personnel who should be involved in this validation process. We will gain familiarity with the competency rate that is required for validation. The authors very nicely gave us diagnostic categories that can possibly be used for validation studies. And at the end, it's also important to understand that there are limitations to this process and what are the possible causes that can cause false positive or false negative results. So at this point, I would like to ask the authors what prompted them to start the telecytology process for roles in their institution.
Well, first of all, thank you very much for having us. It's an honor to be having our article presented here. So, you know, in large centers where you have a fellowship program, we do have our fellows doing most of our rapid on-site evaluations. Occasionally, our cytotechnologists are involved with that too. But as the clinic becomes busier and busier and we have more cases, sometimes you end up having to be in more than one place at any given time. So that was one of the reasons to be able to monitor all these rapid on-site evaluations without like running, really running with gym shoes running sort of thing, to be in different places. So that was one of the ideas. The other idea is also a time-saving way, because if you're actually able to have these, then you don't end up having to travel to, if you have telepathology, you don't end up having to travel to these locations. Albeit they're close, they're within 5 minutes of walking, but you know, maybe you are able to take care of one other surgical specimen or do one more thing during that time. So it was more of a time efficient management. And the third reason is ultimately, you know, when we are raising our young, so to speak, and we have our fellowship program, there has to be a graduated responsibility for these individuals. If you think of it in the surgical specialties, for instance, you know, you have a first year, second year resident going into surgery and maybe doing, you know, an appendectomy by themselves, and the last minute the blessed attending shows up. So why not have something like this for us? Yet you have some sort of control and oversee of that without really virtually or physically hovering over the fellows. So that was another way to sort of give them a little bit more of a freedom, especially towards, you know, the second half of their training program. So multifactorial.
Yeah, and I think telecytology is helpful. Roles by telecytology is helpful to, I think, all practices of all sizes, whether they're academic or not. Like you said, because of their cost and the time saving that is involved with it. With minimally invasive procedures gaining widespread acceptance, ROSE has become very important. We want to make sure that the procedure is able to provide us with adequate material so the patient does not have to come back for a repeat procedure. And we want to be able to triage the specimen that we get appropriately for the same reason, to avoid a repeat procedure. Telecytology can make ROSE more time and cost effective. So per the authors, their aim for this study was to validate their new telecytology system and to outline a telecytology validation process that can be used by other cytopathology departments of different sizes and with different variety of cases. So a little bit of other background from other studies. So if we look at the time saving for pathologists, this study compared the time that is taken by telecytology versus actual on-site roles, and it can substantially reduce the time that is taken for rows by cytopathologists. So it can go down from 21 minutes for on-site rows to 3 minutes by telecytology. This study also showed that there is a decrease in non-diagnostic rate from almost 8% down to 4% if telecytology is used. They did not discuss the reasons for this decrease, but I'm assuming that there is consultation from experienced faculty, more than one faculty member may be involved. that can probably reduce the non-diagnostic rate. There wasn't much change in the deferral rate, and telecytology correlated well with the final diagnosis at a rate of 96% compared to on-site rows, which was 92%. So for performing telecytology, there can be different modalities that may be used. One method is to just transmit static images. So we take representative images of the slide, and those are transmitted to the cytopathologist to render a diagnosis. However, this prevents getting a full picture of the slide, and only representative sections are submitted. So we need a very experienced on-site operator to be able to do this to get a good correlation with the final diagnosis. The second way of doing it is dynamic cytopathology, where a live streaming of a video can be sent while the operator is looking at the slide. Again, this requires an experienced cytopathologist or a cytopathology fellow who has experience with cytopathology. And the faculty member can then, or the cytopathologist can then, can look at the slide and get the image of the whole slide for rapid on-site evaluation. The third methodology that can be used is robotic telecytology, where on-site there is presence of a mechanical stage on a microscope. The slides can be fed onto the mechanical stage, and the cytopathologist can then move them and move them around as per their own and look at them on their own. So the advantages of this are that an on-site experienced operator is not required. Somebody outside of the pathology department can also make a smear and feed the slide in the mechanical stage. However, it is very costly, and it also requires to have a proficiency maintenance for somebody who's outside of the pathology department to be able to do this on a continuous basis. And the last way of doing telecytology would be with whole slide imaging. However, this is very time consuming. As we know, whole slide imaging requires time for imaging and the images to be sent. And then there is a problem with focus or Z stacking. So it may not be the most ideal way of doing rows if you're not able to focus and look at the cells of interest appropriately. So in the study that was performed at the Loyola University, dynamic cytopathology was used. So I again wanted to go back to our authors and ask why they chose that as compared to the other modalities.
Also a very good question. Levent, you want to take that first?
Yeah, definitely. So again, thank you for having us and considering our paper for this journal club. So in our kind of in our practice, we have already a camera set up on the microscopes, and we have different sites for on-site evaluation. So the easiest answer to this question is the cost, obviously, because robotic technologies are quite costly comparing it to dynamic telecytologies, and then it will require a lot of IT maintenance and whatnot. But for dynamic telecytology, we already have microscopes and camera set up on the sites we go for on-site evaluation. And on the other hand, we also, as Dr. Barkan mentioned, we have fellows training in fellowship training program. So it would give them some sort of autonomy to show pertinent areas on a slide rather than having cytopathologists just remotely managing the slide. So that's these are the two main reasons why we used dynamic telecytology.
And if I may add, for individuals who are listening to this conversation and thinking, well, maybe we could do it too, depends on really the cost. The easiest, the cheapest way would be the static telecytology. Even with a small handheld device like an iPad or something like that, static telecytology is doable if you are unable to get a full camera. However, if you can get a full camera, it gives you a little bit more of a overview of the case, just like you said, Dr. Walia, that you can actually see the rest of the case if needed, if it's earlier on, or the operator isn't quite sure of what they're looking at. And if you are an institution with an infinite amount of financial resources, lucky you, then you can get anything and anything you want. You can get robotic, you can get whole slide imaging, you can get a mishmash of all and put it in all these different sites. So that is kind of how I would look at it. And that's why we kind of fell in the middle there with the dynamic telecytology too.
So I guess everybody has to decide what fits best for them. And so we have various modalities. And we will be talking about how we validate it, or how authors validated it. So the American Telemedicine Association recommends validating any telepathology system before it is implemented in clinical practice. So there are a handful of studies that have shown how this validation process might be done. However, there is no good agreement on the details that laboratories might be looking at on how to perform the validation process, especially in terms of how many cases can be used or should be used, what is the rate of concordance that we should be looking at, and what kind of diagnostic categories should be used. So in terms of diagnostic categories, for example, we have the Bethesda system, the Milan, the Paris, and so on. I was wondering if you would like to call this the Loyola or the Illinois system for diagnostic categories, because you did provide a framework for that. This was performed as a retrospective study. So the authors basically took consecutive cases from the previous 6 months on which ROSE was performed. The cameras and the software for the images were set up at all the remote sites that are utilized for ROSE, including interventional radiology, endoscopy, bronchoscopy, and ultrasonography suite. And the images were then transmitted. So it is important that this study was performed in 2 sessions, and I will go over the details of why it was done. For the on-site operator, a cytopathology fellow was the on-site operator for this study. There were a total of 6 cytopathologists who participated in this study. All of them were available for the first session and 4 for the second session. None of the cytopathologists or the cytopathology fellow knew what the original adequacy assessment was or the original diagnosis was. All they had were brief patient histories. So it simulated the live rapid on-site experience. So there was a number of slides that were looked at, 123 aspirate smears from 52 patients. These included 20 thyroid, lymph nodes, lung, liver, pancreas, and abdominal mass. So a good variety of cases that we normally would get in our practice. To simulate, again, real life, the cover slips that were present on DivQuick slides were removed. And then there were 6 cytopathologists. So the 2 tiers that were performed was the test tier and the real tier. And the cases were divided up as 13 for the test case tier and 39 for the real case tier. 3 broad categories were then recorded. The first category was whether the specimen was adequate or inadequate. That was obtained. So first broad category was adequacy. Second broad category was diagnostic category, in which the smears were either, if they were adequate, were they negative for any malignancy? Were they atypical or suspicious for malignancy, or were they positive for malignancy? And the third broad category was specific diagnosis, if it could be provided or not at that point in time. So then the observations that were obtained were compared to the final diagnoses. The cases that were non-diagnostic were not included in the diagnostic categories, means they were not clubbed in together with either with the negative category as this has been done in other studies previously. Then the data was analyzed using RStudio software, and p-values less than 0.05 were considered significant. So I'm going to go back to the authors and ask them why they decided on comparing their observations to the final diagnosis and not to the original Rose diagnosis. What was the rationale for that?
I can take on this question. So our case set was it consisted of cases with no discrepancy in Rose and final diagnosis in terms of adequacy assessment. So all cases with Rose diagnosis of non-diagnostic was also non-diagnostic on the final report. So therefore, it wouldn't make any difference had we compared them to the Rose diagnosis versus final diagnoses. But thank you, Dr. Walia, for reading our article quite carefully, because when we started in preparations for this journal club, we went back to the article and we saw that it wasn't clearly stated the Rose and final diagnoses actually were matching in our cohort. So thank you for that. But yeah, it wouldn't make any difference for our evaluation anyways. Thank you.
Yes, so yes, the final diagnosis would be your gold standard, right, to compare and see how you did with telecytology. So excellent. So again, so the two sessions, the first session was the test session, and the test session was performed just to make the cytopathologist and the cytopathology fellow familiar with the process, the technology of how the images are sent, the communication, to see if there could be any hurdles that need to be overcome for the actual real session. So it's important to do that before the actual validation study is performed, so that a good concordance rate can be reached. All the problems can be resolved prior to the actual session. In this test session, only adequacy observations were recorded, so the other diagnostic category and the specific diagnosis were not collected for this test session. So in keeping with real life, there was a mixture of non-diagnostic cases and diagnostic cases. There were 15% non-diagnostic cases, and the rest were diagnostic cases. Adequacy concordance for the test session was overall 83.3%, which is 65 of 78 observations. And that was expected because people were still getting familiar with the process. So the hope is that will improve in the next session when people are more familiar with the process. The second session was the real assessment for validation. Here, in addition to adequacy, a specific diagnostic category was also recorded by the cytopathologist. However, if they could not make a specific diagnosis, that could be left blank. So it was okay to say, yes, it is malignant, but it didn't have to be like it's an adenocarcinoma versus a squamous cell carcinoma or so on. So a diagnostic category could be left blank at that point, as long as a category was chosen as either suspicious, negative, or malignant in adequate cases. So again, for the real case set, there was a mixture of non-diagnostic and diagnostic cases, similar to the prior. This study had about 13% non-diagnostic cases and 87% diagnostic cases. And as you can see, the adequacy concordance increased from the test to the real case set. So it became close to 95% adequacy concordance, which means the specimens that were called adequate on Rose telecytology were adequate for the final diagnosis. That concordance was 95%. And this was statistically different as compared to the test session, where it was in the 80s. So an improvement was seen. So here is a table which tells us what the observations were. So please note that the table is meant for each smear, not for each case. So there were 11 cases, 11 smears that were called non-diagnostic on rows, which ended up being diagnostic on final examination. But for the remaining, all the observations, they were concordant. But these are just 11 smears, and they belong to 3 different cases. In terms of diagnostic category concordance, the overall concordance was again greater than 90%. It was 92%, which means all the cases that were called negative on telecytology rows, 90% of them were also called negative, and so on. The positive cases were called positive, and we can understand this better with this table here. We have the final diagnosis line, the horizontal one, and then the observation is on the vertical. So as you can see, most of the negative cases that were called negative on rows were finally negative, and similarly, most of the positive cases were finally positive. 2 of the negative cases were called atypical or suspicious on final diagnosis, but none of them were called positive. The atypical or suspicious category also remained in the majority, were concordant by 24 cases that were called atypical or suspicious in rows were also called similarly on final results. However, there were 4 that jumped to negative and 5 that were called positive, which is expected of this category because this category is kind of an ambiguous category. And then 3 cases that were called atypical or suspicious, 3 cases that were called positive on rapid on-site evaluation using telecytology were finally called atypical or suspicious. As you can see, there is not any jump of two diagnostic categories in any of these cases here. So in terms of specific diagnosis, for example, saying whether it's a melanoma versus not, the concordance rate overall was 88.1%. And here, basically, the most discrepancies were noted between when there was cytopathologists were trying to differentiate whether it's a squamous cell carcinoma versus an adenocarcinoma of the lung, which were 3 of 12 observations. Again, very difficult, I think, to do that on DiffQuick, air-dried slides on rapid on-site evaluation. So validation is necessary to ensure the quality of patient care and consistency of the method. So one of our things that this paper tells us, and that I would like the audience to get away with, is that a concordance rate of over 90% is a good concordance rate for validation studies. And this is required for adequacy assessments as well as for diagnostic categories. So there hasn't been any prior study that has provided this number of 90% before. So thank you for helping us with that. In terms of diagnostic categories, also there isn't a good diagnostic category that has been provided. So these are a handful of studies that have done prior validation studies. They range a lot in terms of the number of cases they used and the final concordance that they received. The study that was done by McIntire et al., they used 10 cases that were randomly selected in their lab, and they compared rapid on-site evaluation by telecytology to final diagnosis, and also rapid on-site by telecytology to actual view under the microscope. In this study, they do not have a non-diagnostic category as a separate category, and then they combine that with the negative category. So they used 10 cases. And then the next study, which was done by Goyal et al., they did not have any non-diagnostic cases in their series at all. They did use a 2-tier, similar to the current study, where they had a test tier and a real tier. And in this study, they reported 100% concordance with the test tier. The real tier, they did have problems because they used EUS with pancreatic specimens, and 3 of their cases that were called positive or suspicious for malignancy were eventually negative. And we have, again, all been through there where we have chronic pancreatitis with very cells that look really malignant on rapid on-site evaluation, but may not on final evaluation be called malignant. So for the audience, please be careful of false positives, especially when we're dealing with telecytology. We do have to know whether the patient has a history of prior pancreatitis, if possible, and call our diagnosis as such, like we do in real life. Another study that was done was Agarwal et al. They basically had a smartphone camera that was attached to their microscope, and they relayed images from that smartphone to a tablet to the cytopathologist. They reported an 88% adequacy concordance in their first year, which is the training phase. However, they did have technical issues in the second phase of their testing, and their concordance rate fell down because of that. Their study was to basically test low-cost telecytology using existing cameras on phones and tablets. But however, we have to be careful of technical issues when we're using such a technology. So if we come to the current study, there was an overall concordance rate of greater than 90%, which is required, close to 95%. And then another important thing that this study told us was that we have to have a non-diagnostic category, and that the number of non-diagnostic samples should resemble what we have in real life. So they used a number of 10 to 15%, which is what we normally get. And non-diagnostic categories and negative categories should be separate. They should not be combined because they're not the same. So what happened to the 11 cases that were called non-diagnostic on rows, but ended up being diagnostic on final evaluation? So these 11 smears basically belong to 3 cases. And this, again, similar to real life, the diagnostic areas were small and composed of very few cells. It is possible that the on-site operator did not have enough experience at that time to locate that scanned diagnostic material. However, the authors do make a point that if it is a scanned material, it is better at that point to collect additional material to be comfortably be able to make a diagnosis. While we're still there, the procedure is still going on. The chance of complication of getting additional passes is really low, and it is less than getting suboptimal material. The authors again tell us that we should have they give us some direction of what kind of diagnostic category system we can use. In this study, they used negative, positive, and atypical or suspicious. Negative were used for all the benign cases, for example, granulomas, abscess, benign neoplasm, and normal tissue, if those were sampled. Positive was used for all the malignant cases, and atypical or suspicious were used for atypia, which could be neoplastic or reactive in nature. So they could not be called negative or positive on rapid on-site evaluation. And overall concordance, again, here was greater than 90%, almost 92% was achieved. In terms of giving a specific diagnosis, do we really need to do that at rows is a question that we haven't really answered. I don't think so. It is required. The concordance rate here was 88%. In terms of validation studies, determining a cutoff point for specific diagnosis may not be necessary. So the recommendations from this study are if we are performing a validation study for telecytopathology in the institution, perform it in 2 steps. a training step to get everybody familiar with the process, to get over any technical hurdles that there might be. And after that, do a validation, actual validation study. So the number of cases that can be used, since this is more of an adequacy assessment and not a diagnostic assessment, we may not need 60 cases that have been recommended by some authors. We could include 10 to 15 cases in the training set and 30 to 45 cases in the validation set. This validation study should simulate real life and include non-diagnostic cases, and it should include a mixture of cases from various organ sites. So one of the objective of this presentation was also to understand which personnel should be involved in this validation study. So all cytopathologists and all the on-site operators who are going to be using this process by telecytology should be involved in the validation process. So all cytopathology fellows, cytotechnologists, cytopathologists, everybody should be involved in this. And if you're using a dynamic system for validation studies, it is important that all the cytopathologists do this validation study at the same time. So they're reviewing the same images, and there isn't a discordance in the images that were viewed at different times by different pathologists. We have to ensure that the test adequacy concordance rate is real without crediting for discrepancies for adequacy assessments. So in terms of diagnostic categories, the authors give us a direction of what can be used. They used negative, atypical, suspicious, and positive. And we can follow that or tweak it based on our preferences for the lab. But they do give us some direction here about that. Also, non-diagnostic category should not be included in the negative category. Concordance rate, as we talked about, should be greater than 90%, both for adequacy and for diagnostic category concordance. If there is a failure, we do not reach 90%, the validation study should be done after a washout period. Some studies have suggested like a 2 weeks washout as a minimum washout period to perform the validation study again. So this is basically what was done. Image A shows the presence of diff-quick slides that were, the covers were removed, the slide covers were removed. Slide B shows the cytopathology fellow reviewing on-site images, and they can also be seen being transmitted on the screen. And on the right part of image B, we can see cytopathologists who are together and looking at the screen, blinded to the original diagnosis and not talking to one another, but making their own diagnosis. So part C, they made their diagnosis for adequacy as well as diagnostic category, and if possible, specific diagnosis. And then the data are compared to see what concordance is achieved to the final diagnosis. So I go back to our authors and ask them, how is the process going on now? This is obviously a retrospective study. How is it with the live telecytology?
Also a very good question, and very, very nicely presented, I must say. So after the validation process, what did we do on the back end was, I again collected everybody and we went to at least one of the sites and I showed the fellows, and as I do every year when they start, this is how to start the telecytology process. This is how you share your screen, that sort of thing. And we also had additional setups for the individual pathologists so they know how to use it in their own. Maybe they're not back-to-back cases, or they're not simultaneous cases, and they're like, well, I need my 10,000 steps, let me just walk to that location, and they go to that location. Occasionally, maybe there's a technical glitch in the computer system, and then they're like, okay, let me not deal with that. But some of us are using it more regularly than others. So at the end of the day, it actually helps. To me, still it is a very good way of teaching our fellows, because if you are going to graduate, in June, you should know what you're looking at, and you should be comfortable with what you're looking at. Therefore, it is helpful, at least for the training purposes.
Yeah, good to know. So it has a mixed use, it seems, at the end of the day, but if somebody is very busy and not immediately available, it is a very good system to have, to be able to review it.
And also, there are other things came up. We are in a integrated medical system with multiple institutions. So therefore, occasionally they change the computers, or they scan the computers and some of the software goes, and then you have to be on top of it to make sure that, at least the camera software is there, and then find maybe alternate workaround ways for screen sharing such that it is still there. This may or may not have happened, say, if you had a more expensive system, like the whole slide imager or something like that. But then some of those are so cost prohibitive that the vast majority of us in the trenches, the institution will not be able to afford such a system. So you have to go with the path of least resistance, where you can actually obtain this and make it as technologically as easy as possible for the endpoint user, because even if there's a little glitch, humans are like, well, this is not working, therefore I shall not do it. So, we have to find ways to make sure it is very, very user-friendly and easy.
So it's an excellent study, but no study is without limitations. This has a few as well. So it's a retrospective study. We do not have any prospective post-implementation data. So instead of using a statistical analysis to determine how many cases might be required, a more practical approach of using past 6 months retrospective cases was utilized. So the author suggests that further large-scale studies need to be done to see what minimum number of cases may be required for telecytology validation studies.
And that is a very important point. Let me cut you. I'm sorry to do that. But one of the sort of seminal papers written on telepathology is from Dr. Pontonowitz at University of Michigan now. And in his archive study, backed up with the College of American Pathologists, they looked at the validation with 60 cases. But really, that was for diagnostic evaluation of those 60 cases. When you think of it in real life, in roses, most of the time we just give an adequacy. Yes, you have enough follicular cells, therefore it's an adequate thyroid sample, but you're not necessarily saying, benign thyroid nodule or this or that. So really the question is, in case of adequacy, do we really need the 60 cases? So with this study, we couldn't come and answer that particular question. However, if there's anybody listening and has a mathematical mind and could come up with a mathematical model to say, for this, you actually need this much of cases. Is this really 10, like in one of the studies, or is it more? Probably less should be enough, but I think a study like that needs to be done. Just throwing it out there to whoever listens.
I think it'll be useful for everybody.
Very good. I think I'm sorry, Dr. Walia. I think part of picking up how many cases will be, appropriate for your adequacy and all of that by validation, maybe has to do with the number of the operators. If you have a very large department and have very many people involved in it, you may need a bigger sample size to kind of, you know, take away all the nuances that come with many different people's different ways of doing things. I think that may be something to kind of be mindful of it. But I think what you have done, and especially with your setting, seemed to be perfectly fine for the number of people who are doing it and number of cases that you are doing it. And also depending on if your rows inadequacies are mainly for superficial samples like thyroids, or you're doing mainly for deep-seated samples such as EBUS and EUS, because obviously those have their own you know, pitfalls and problems. Again, this is just something that came to my thought. I don't have any good reason to say that, but I think it matters for where you're going to use your system. So this was very good, actually. I think has a lot of practical value, and I'm sure many places, whether they like it or not, whether they're doing it yet or not, at some point they will go in it, because as you mentioned, the time aspect of it by itself, short of cloning ourselves to be in so many places, doing so many things at once, which we have tried to do at so many levels in the world of pathology for sure. But short of doing that, you can't just go on going to an adequacy for, I don't know, 20 minutes, 30 minutes on a case, and then having your slides and piles up on your desk at the same time. So I think it's a great thing to kind of start looking into it the way that you have done objectively, because we all have to validate things, whatever we do. So I think this is very good, and it was very well presented, and you guys helped us very much to understand it. I have a couple of questions. If we're done, sorry, Dr. Walia, I jumped in.
No, I was done. So
Okay.
yeah, these are objectives at the end, and I'm hopeful that the audience are able to get that from us. So we'll go to questions, Dr. Razai. Thank you.
So sure. One question that I had at the beginning: what staining was used? What the staining methods was used, both for the real cases and for the study sets? And I think you guys mentioned it at some point, but just go ahead and make sure that we have that.
So we used DiffQuick, and as we mentioned, this was a retrospective study. So these were the DiffQuick slides that were actually done on site at the time. But afterwards, they're cover slipped, and we uncover slipped them to simulate a real life situation, and then had these slides of DiffQuick stain slides at the location where it actually happened. The microscope and the camera was there, and it was projected to the conference room where the rest of us were sitting.
Very good. There was also another question that was about that, you know, the same thing that you said, how is the maintenance of the systems? And we kind of know how IT systems and IT workers work with us. And so one thing is that, so obviously you brought it up in a sense, and I know that upgrading the systems that happen in any institutions at some point, I kind of like that they call it upgrade, but somehow the next day everything is kind of gone from your computer. You can't exactly. So I think that's something that is an IT issue in general for anything in what we do. But also was the question that, you know, so do you have I guess within your presentation, there were times that we were talking about in other studies that, you know, how much time was saved between doing it with rows or with telecytology versus kind of going in person. So you guys, I'm sure you kind of have an idea how much time saving was for you.
So in our study, we actually didn't look at the time saved, the time we go over there. But, you know, as we all know, when you have an FNA, and there's a very elegant study done by Sarah Monaco showing that, where she says, you know, you can save up to 80% of a pathologist's time. Right. And that really is important, and I'll tie it to a study done by my colleague, Dr. Swati Mehrotra, a number of years ago here. Time is money. Right. So those the time that you spend doing a rapid on-site evaluation being a wallflower in an EBA suite might be 45 minutes, and you know what the billing code for that would be and how much revenue you would generate from that, as opposed to 45 minutes if you're sitting in your office and you are looking at small biopsies, 88305s. You can imagine there's a vast difference between these two. So yes, it is time saving, it's revenue saving, but really at the end of the day, you have someone who has a little bit of a trained eye to be doing the endpoint where they're actually showing the slides too. So that would be very well done with a cytotechnologist or a cytopathology fellow, or maybe some of the residents who are interested in cytology also. Just a quick parenthesis for your previous question, what stain we did the roses or the validation with. When we did it with DiffQuick, but if there's an institution and say, for instance, they do H&Es and that's how they do their roses, they should validate their study using H&E stain. So do what you do in the validation as what you do in real life.
Real life, exactly. No, that's a very good point. I'm glad you brought it up. I have actually one question, and I kind of wanted to know, actually I have two questions, but one of them is more important. I know that in your diagnostic categories, you have your negative, you have atypical/suspicious, and you have positive. For me, again, I don't know, maybe the way that I usually do, and I think the clinicians also react to our diagnosis, suspicious for them is kind of like positive. So they kind of take it to that further step. Whereas atypia, when I'm saying atypia, is meaning that I really can't say whether this is a reactive atypia or is it a neoplastic process. Was there any reason that the way that you lump the atypia suspicious together, or is this something that is your practice in general, that's what you do?
No, in this setting, like atypia and suspicious, and you're very right. Like when you think of like the Paris system and urines, when you say suspicious for high grade, that really says, it is there, it is positive. I only saw 5.5 cells. Go find your source is what you're saying there. In this case, it's just putting the equivocal diagnosis together. Like one is negative for sure, negative. The other one is positive for sure. And then there's the kind of shades of gray in the middle. In reality, in reality, when you think of rows, the most important reason for rows is to give a, adequacy. Like, did you get enough material? Such that when I go back to the lab, am I going to be crying in 2 days because there's not enough material and I can't give you a diagnosis? So if you are actually able to give a yes, adequate, or no, not adequate diagnosis, really that kind of covers. If you're taking it, and per the CAP guidelines too, like, per the checklist, that's also okay as long as you document it. If you can take it one step further, and as you said, we said 3, but really it could be a 4-step diagnosis with negative, it could be a suspicious and positive. That's great. Really, there's no reason to say, this is adenosquamous carcinoma of the pancreas. You know it, great, that's wonderful. Maybe keep it to yourself, because otherwise they're going to say, oh, you don't even need the immunohistochemical, you don't need anything.
What is your turnaround time? Just give the diagnosis, right? I know. No, absolutely is very correct. So let me see, there is one question. How is the buy-in by your pathologist? In an unpublished pre-COVID CAP study, less than 10% of pathologists had any experience with whole slide imaging or telecytology. A few institutions have a lot of experience, but for most it is not the case because the cost of the system, unfamiliarity with the technology, and system stability. So I guess the buy-in from the colleagues.
That is a fabulous question, and buy-in is important. So when you're thinking of a buy-in, why would you buy into something? You would buy in if there's anything in it for you. So what is in it for you? What is in it for you? If you have a busy service and say any given cytology day, you have 40, 50, or maybe sometimes 60 cases, that's a busy day. And if you are getting up every half an hour to go to an FNA, and you're doing the rapid on-site evaluation and spending another 20 minutes, that means your day is going to be a pretty darn long one. You won't be able to go home for dinner. So the question is, do you want to go home for dinner? And do you want to make this a little bit more of an efficient process where you can do this? The second thing is, how can you make this more, like I said, technologically easy? Not all of us are technologically savvy, right? I mean, you know, if it involves more than a couple of clicks, you might get some anxiety attacks. Where was the link? What am I doing now? Why didn't it work? So it has to be a relatively simple process for people to follow. That's the second buy-in, because they are able to do that. And once they see that they're able to do that and it works, that is great. In our situation, did everyone buy in? At front, they did buy in, but then they're like, well, maybe I need to get my steps in. I can't argue with that. You're right, you got to get your steps in. So you have to find a balance of when you use it and when you don't.
My personal experience was that it kind of, even though we wanted to bring it on with the intention of cytology and rows, but till we kind of get that settled with our clinicians and our institution and everything else, we had the capability. So we used it for frozens, and that actually helped a lot, because at that point we were going into different locations for the sign out versus the hospital and all of that. So if you were the person that somebody wanted to show you something and you were not physically in the hospital, that just made the whole lot of difference. So I think once that happened, people kind of felt more, I guess, sympathetic towards the whole, you know, telecytology aspect of it. So I think, and as I said, I think it eventually will be. One question that I also had was about the robotic ones. And again, I don't know if you offhand, when you were looking at different, you know, systems and getting, how often our pathology departments are using the robotic system?
So yes, so this is interesting. We did have a couple of vendors coming in and talk to us about, you know, if this is a possibility. There are a couple of them out there that is really wonderful. All you have to do is train the, again, the endpoint person said it's EBUS or something. You have to still train them how to do the smear, because although these days there is a machine that actually can also do smears, so all they have to do is the drop, you know, of the FA into an equipment, and then that makes slides, and then they could just take that slide, and those equipments in fact also stain them, and then they would have to put it into the robotic equipment and do that. And I've seen it in action. Yes, it's very nice, but it breaks down on the heat of the moment. What now? You know, it has to be done. The other thing is, it was pretty expensive, at least for our institution, to be able to handle that.
Absolutely. No, absolutely. I kind of don't like to give up the ability to be part of the spearing process. When we send our fellows or cytotecs, they know what to do with the sample, because we have vested interest in what comes out of that smear. Whereas the clinicians, or even if the nurse practitioners or MAs or whomever is in that room helping the clinicians doing that, they may just think, oh, we got a lot of material. They put all of squirt it on the slide, and then all you have is blood, and then everything is trapped in the blood. So I think, yeah, unless you have that ability to have the smear maker and again teach them not to push everything that is in the syringe or in the top of the needle on the slide, I think that can wait longer, and maybe the cost come down a little bit. I don't know.
Exactly.
But yeah, but I think really the dynamic one, the way that you described it, I think most places who have some sort of a telecytology capability, they're using some sort of that, you know, setting. So I had not heard about places that at least I know of doing the robotic one for the practical day-to-day practice. I may be wrong, and if they do, good for them. But I think this is really, it will be probably the bread and butter of doing telecytology, at least for the time being.
I think one of the cases that it could be useful is, say, you know, again, now we have these healthcare conglomerates and they keep on buying new hospitals and saying, here's your new hospital, now man this hospital, go for it, sort of thing. So in situations like that, and this hospital is, say, 100 miles away, nobody's going to drive 100 miles one way to do an FNA.
Yeah, of course,
and it's impossible to always be able to stick a pathologist in that site. So that might be a situation where you have this expensive equipment, one time only, that you buy and put it there and teach them how to use it, such that, you know, then it would allow humans not to have to go to that hospital, you know, in person. With that same token, one of the uses for our you know, screen sharing of the telecytology or telepathology is we do also have these sort of other hospitals that we have to man, and it might be that you are there by yourself as a pathologist and you might have a case to show to others, and collective wisdom of the group, and this is a perfect way to do that. And this is happening more and more. I'm sure ours is not the only one in the country, where you have lots of other hospitals attached to the main hospital. And there you are there by yourself and you need help from your friends. And this is also a very, you know, good way of doing this.
Very good. So you have thank yous and appreciation of your presentation. One coming all the way from Switzerland. So that's very good. An international presentation. That's very good. So let me see. Do you have any experience? Sorry, I know that we're running out of time too. Do you have any experience with telecytology with a mobile phone adapter? Actually, I think we talked about it. I don't think you guys have experience with that, right? But there are people who have done it.
Validated, but when it first came up, there's different adapters, and now they're actually relatively cheap. They're under $50. You can find it, and if you're really technologically savvy, you can 3D print it, and all you do is you attach it to your microscope, such that, you know, when you're using your handheld device, your camera, you could just attach it there and take the pictures. That would be probably the most cheapest way of doing it. There are, of course, some issues, like it's not your cell phone's camera might be very good in taking your kids' pictures, but perhaps it's not as good as taking microscopic pictures. But if you're doing it for adequacy purposes and you have nothing else in hand, that's a perfectly viable method.
That would be static too, right? But not a dynamic. That would be static images too.
That would be static, or if you open up the you know, the camera in such a way that it's just open and you're not taking pictures, so it's almost like a video that you are, whatever you're seeing in your microscope and your camera is open, it could be what they're seeing there. Now, would it be, you know, crisp focus and beautiful pictures? Probably not. But is it enough to say, hey, this thyroid has enough follicular cells? Yes, it is. So
very good. Very good. I think we're almost out of time. I encourage other people, if you have questions, just send it to us at the ASC, Dr. Walia and myself. We can also look into it and send it to Dr. Barkan and Dr. Trabzonlu, so just to kind of get a better answer for it. But it was great to have you both here, and thank you, Dr. Walia, for your very thorough presentation of the findings. And I hope it's very helpful for people who are thinking or in the process of adopting a telecytology system, because it's good to have at least some idea of how to go about the validations. Validations are part of the life of pathologists every day for anything that we do. Even if you want to move the machine an inch over there to the side of the histology lab, you have to validate it again. But this was wonderful. Thank you very much. And if everybody else is good to go, we can kind of end the session.
Thank you very much. Thank you for having us.
Thank you so much.
Thank you very much.
Very good. Very good. Bye.